good afternoon, everybody. The talk I'm about to give is a very practical one, and it's in many ways a reiteration of what we heard from Eric earlier on today about the role of the pathologist in really responding to and coping with all the changes that have occurred in the management of patients with lung cancer over the last decade. There are my disclosures. The service I provide in Liverpool is really in two parts. There's a service in diagnostic thoracic pathology for the city of Liverpool, which is about 450,000 people, and that material comes through to large university hospitals and the regional thoracic centre. And then there's a service for the larger region of Merseyside, which extends north and eastern Liverpool. It's about 2.6 million people. And for them, we have a service in thoracic surgical pathology. All of the resections are done in Liverpool. We see about 450 a year now. And we also provide a service in the profiling of newly diagnosed tumours, which is a more wider service than the Liverpool region. That's just to put things in context. So we see an awful lot of lung cancer in Liverpool. And the changes that have taken place over the last decade, I think, are probably best illustrated if I show you two pathology reports of mine. This is one from just over 10 years ago, which at the time was considered entirely adequate, although it would not be now. You can see it's a report on a needle biopsy from a mass in the left lung, cause of white tissue. There's a paragraph describing the morphological features, which says essentially this has features of adenocarcinoma, it has some features of squamous carcinoma, it is a diagnostic of neither, and therefore it was called a poorly differentiated non-small cell carcinoma, probably adenocarcinoma, and left at that. Now, here's the exactly equivalent report from last year. And I don't expect you to read that, but I think it makes the point very clearly. What you might call the traditional pathology is confined to the third paragraph down on the left. There's a little bit of immunochemistry, which allowed me to say that this was, in fact, an adenocarcinoma. And then the rest of that report is essentially genomics. And the important bottom line, it's not actually at the bottom, it's about 2/3 of the way down the right-hand side, which says that there's an L858R mutation in the EGFR gene. And if I'd have shown that slide a month from now, there would have been a paragraph about PD-L1 expression, because we're one of a few laboratories in the UK who are in collaboration with the big players in the pharmaceutical industry who are bringing these drugs to market, about to start testing for PD-L1 expression. I'll return to that a little bit later. So things are evolving all the time. The momentum is still gathering. Why has that happened? Well, it's happened because of the advent over the last approximately 10 years of lots of new and very elegant drugs which allow much more precise management of lung cancer, but carry with them implications for how the pathology is performed. And I've divided them into these three broad groups. The first group there are therapies which are dependent on very basic histopathology. Is it squamous or is it adenocarcinoma? For example, the antifolate pemetrexed won't work on squamous differentiated tumours. They're full of adenylate synthase, and it's an antifolate, it's ineffective. So it's not rational to use it in that instance. So with drugs like pemetrexed, bevacizumab, which can actually be dangerous as well as ineffective in squamous differentiated tumours, it's important to get the basic pathology right, to use them rationally. Then you have a big and ever-increasing group of small molecule tyrosine kinase inhibitors, and we're very familiar with these now. Now, at the moment, these are essentially active against tumours that show EGFR gene mutations and tumours that show ALK rearrangement. Now, the reason you have to make a precise diagnosis with this group of drugs is that we tend to refine the population we test according to whether they're squamous or non-squamous. That's because these genetic abnormalities are almost exclusive to non-squamous tumours. So there's no rationale behind looking for them in squamous differentiated carcinomas. In addition, however, of course, looking for ALK gene rearrangement, as we've already heard today, is about looking down the microscope at sections either labelled for ALK fusion protein by immunochemistry or indeed fish preparations. So this is pathology. And then there's this third group at the bottom, which we've heard a lot about today, the new immune modulators. Many, many problems around this area of diagnostic pathology and indeed in terms of management. And here, of course, again, this requires the use of a microscope and the scrutiny of immunolabeled slides. So this is a new technique which pathologists are having to learn. So there have been many implications for pathologists over the last decade. And what do we need to do a good job? What do we need to do? Well, I'd reiterate the first point, which is largely out of the hands of the pathologist. We need a good specimen. We need an adequate specimen. And this point has been well made by Eric and others. I'll return to it in a minute. And then we need to get the basic diagnosis right. Is it definitely a primary tumour of the lung? If it's a carcinoma, is it small cell? Is it not? If it's not, is it squamous? Is it adenocarcinoma? Is it something else? We have to get that right now. It matters more than it ever did. And when we move on to looking at the genomics, the genetic abnormalities, the downstream effects in terms of protein expression, we have to get that right. There's an often very flattering assumption that what the pathologist says has to be correct. It's not maybe a wise view to adopt. We do our best, but this is in many ways a subjective science, and there is a lot of room for error, and it's often not appreciated. A lot of this is very subjective. And then finally, once we've done all this information really has to be properly integrated so it's useful clinically. It has to be combined into an overall profile of the tumour. So let's look at these in turn. Adequacy of the specimen. There is no such thing as a biopsy that's too big. That doesn't exist. The ideal biopsy is the primary tumour and all of its metastases. If we had that, we could tell you absolutely everything. But of course we don't. So we have to compromise and do the best with what we've got. Now, the picture top left there shows a typical endoscopic bronchial biopsy, 3 small tissue fragments. There they are in the paraffin wax block. Then you see a slide with 3 levels of the biopsy, and top right you see a low-power scanning view of that specimen. Now, that's a very decent specimen. I'd be very happy with that. But if you look at that, you'll see that across the middle is a band of fibrosis, and that's not informative. So if we're looking at sections from that specimen, we have to ignore that. More importantly, if we're trying to extract DNA, there's no point in taking the whole of that specimen and extracting the DNA because it will be heavily contaminated by non-tumour DNA. So ideally, you would need to microdissect that. So that's a good specimen in terms of the number of tumour cells. There will be thousands and thousands of cells in that specimen, but there's quite a lot of non-tumour. If you look bottom left, there's a typical sequence of events in terms of how we handle cytology specimens. Now, we don't in any way assess the adequacy of a specimen with the endoscopist. We don't do that. We do not have a pathologist in the room when the aspirate is taken. I think that's a waste of time and resources. In fact, what we do in Liverpool is we have the aspirate immediately placed in fixative. No smears are made at all. So the second item in that picture there, the slide, is something which we don't handle at all in Liverpool. Everything goes into the fixative, we then spin it down, and we form a paraffin wax block, as shown adjacent to that slide, so that what we eventually end up with, as shown on the far right there, is more or less histology. It's the cells embedded in a block of paraffin wax from which we can then cut sections. And bottom right there is a picture of what we get. Now, there are not many cells in there, but they're all tumour cells. So that specimen may not have as many cells as the biopsy above it, but it's pure, maybe 80 or 90% pure cells. That's a very good specimen for either extracting DNA or doing immunochemistry or whatever you would wish to do with it. So bigger is always better, there's no question about that, but quality is important too, and how the specimen is handled is also absolutely crucial to getting the right answer. And what about diagnostic precision? We can no longer say this is just non-small cell carcinoma. We've known for years that with morphology alone, you can make the diagnosis of adeno or squamous carcinoma on about 70% of cases, which leaves, of course, 30% on which you cannot. And this is the group that we used to call non-small cell and think no more about. And we now refer to as non-small cell carcinoma, not otherwise specified, NOS. Hence, the NOS rate on morphology alone is 30%. And a tumour like that one shown there top left, it's impossible to make an accurate diagnosis with that on morphological grounds. You can't do it. Now, over the last few years, we've addressed very closely the problem of how to come to terms with that and to be more accurate. And there are many guidelines now around the world which have boiled it down to really quite straightforward immunochemistry. And using 2 antibodies, and you generally don't need more than 2, P40 and TTF1, which label for squamous differentiation and glandular differentiation, i.e. adenocarcinoma respectively, we can bring that NOS rate down to 10%. And we incorporated this in the previous guidelines, which are now currently quoted there at the bottom for the Royal College of Pathologists in the UK, and these are the guidelines that pathologists in the UK tend to work to, and we're already revising those for a 2017 edition because of the continuing changes. But they make the point very strongly that with the use of basic immunochemistry, no laboratory should really now have an NOS rate greater than 10%. That really is a standard to which they all should aspire. So we've got the diagnosis right, as far as we can tell. We then think about how to characterize its genomics. And there are all sorts of things we can do, of course, and we'd like to do, we know that. But at its very basic, what do I think we should be doing at the moment? Well, I think as an absolutely basic platform of investigation, we need to look for EGFR gene mutation, ALK gene rearrangement, and imminently and undoubtedly expression of PD-L1. So 2 genetic abnormalities and expression of PD-L1 as a basic profile. Now let's look at these in turn and what it involves in terms of getting the answer. A little bit of revision of the biology there. EGFR gene mutations tend to be most prevalent in peripheral adenocarcinomas, often now referred to as TRU, or terminal respiratory unit adenocarcinomas, because they arise at that point in the lung where the small airways become parenchyma around the respiratory bronchiole. They characteristically express TTF1, as shown bottom left there. It's an interesting and very tight association. That morphology, that location, expression of TTF1. And if you take all non-squamous carcinomas as a whole, in Western populations, about 12% have EGFR gene mutations. This varies widely according to the population you test and, of course, geographically across the world, but in Western populations, it's about 12%. So that just puts things in context a little. Now, all we need to look for EGFR gene mutations is good DNA, and we don't need a lot. We need about 5 micrograms. That's all. So if you have a decently preserved specimen, that's not a difficult requirement. And that machine there, the RotaGene-Q, is the machine we use in Liverpool, and providing you've got good DNA, it's a very robust technique. It looks for 29 mutations, which cover all of the common mutations in EGFR, and it's a very objective test. There's very little interpretation here by the pathologist. The mutation is either there or it's not. So this is pretty straightforward, providing your DNA is adequate, and that, of course, depends on your specimen in the first place. With ALK, it's a bit more complicated, and indeed a bit more interesting, I think. ALK gene rearrangement is typically seen in different type of adenocarcinoma. These tend to be solid with intracellular mucin that form so-called signet ring cells when the nucleus is pushed over to the periphery of the cell. And weirdly, these tumors tend to co-express P40 and TTF1. So they have an element somewhere of squamous differentiation in their makeup, although it's not overt, and it does not mean that they're adenosquamous carcinomas. But whenever I see a tumor with that morphology, I automatically think this is one of those tumors which, if it expresses any apparent abnormality, will have ALK gene rearrangement. And this is a very rare genetic abnormality. I give the figure there of 5%. In Liverpool, we run a steady ALK rearrangement rate of 0.5%, and we think that's real. And again, rather like EGFR, you find if you look at the data, this varies very widely geographically amongst different populations and different tumour groups. Well, how do we look for this? Well, we've heard about this. Eric went into this in some detail. There are essentially 2 ways you can do this. You can either look for the gene rearrangement itself using fluorescent in situ hybridization, shown there on the right. And when you do that, of course, you're looking at the essential biological event, the dislocation of the chromosome. This is not a mutation, it's a chromosomal break and rearrangement. So you use FISH, you're looking at the actual biological event. Now, when that happens, it generates a fusion protein, probably purely by accident. And that's what you detect with the immunochemistry that we've heard about, shown bottom left. So in a way, the immunochemistry is a surrogate for FISH and demonstration of the chromosomal dislocation. Now, the reason FISH was used when crizotinib was under trial and development was that the immunochemistry then was very, very poor. It was wholly unreliable, and therefore FISH became the gold standard. But over the past 4 or 5 years, the immunochemistry has been refined and developed and improved to the point where it is now so closely correlated with the genetic rearrangement that, providing it's done properly to a very precise formula, it is as good in almost every case. And this is a picture of expression of ALK fusion protein as evident with the use of a tightly defined and prescribed method. The Ventana D5F3 antibody, benchmark platform, OptiView detection and amplification. And as Eric showed very nicely this morning, when you use that precise system, the difference between a negative and positive is very clear. It's very unusual to get an equivocal preparation. Most of them look exactly like that. And every Thursday, and not today of course, but every Thursday when I get my pile of 12 or 15 ALK labeled sections to look at, I can usually see the positives in the tray without the aid of a microscope because they're conspicuously brown. And indeed, the US FDA in June last year approved that particular test with that particular recipe as a valid indication of sensitivity to drugs like crizotinib. And the situation now is such that if I have a strong positive, and this is the technique we use in Liverpool, I don't proceed to FISH. I don't think it's necessary. And I will report that as entirely valid evidence for the use of crizotinib, ceritinib, whatever. So this is a very unusual and welcome instance of something getting simpler, which we don't often see. And what about PD-L1 expression? Well, just to summarize the very essence of this hugely complicated area of biology, what it's based on is the simple fact that programmed delta ligand PD-L1 binds with its receptor PD-1, which protects the tumor from immune attack. That's the essence of it. And PD-L1 is on the tumor cells and in the immune cells, which complicates matters. PD-1 is in the lymphocytes. And the other factor which we know without question, despite all the uncertainty, is that PD-L1 expression is related to response to immune modulators that are active against PD-L1 and PD-1. Now, everything else, almost everything else, is difficult and inconsistent and questionable. And in my view, PD-L1 is actually the wrong marker. There's probably a basic error here, and we should be looking for something else, maybe, I think, residing in the immune cell populations, and I think we've heard that opinion expressed today. I think we've got the wrong marker here, but we have no choice now. This is the marker of choice for the 4 drugs which are coming onto the market, and we have to go with this, I think, despite all its problems. And that picture there on the left shows beautiful expression of PD-L1 as identified by the 22C3 DACO antibody, one of only 4 antibodies that are available for the 4 different immune modulators. And the problem is that they don't all look like that. And you might think, oh gosh, it must be easy to look at a section and say whether there's 1% or 50% expression. It's extremely difficult. It's extremely difficult. So very, very subjective indeed is this particular aspect of characterizing these tumors. So once we've done all that and got all that information, I think a very important final step is to integrate it. And that's the report I showed you at the beginning, but the various components are highlighted in different colours. For example, the yellow there on the left is the immunochemistry that defines the tumour as an adenocarcinoma. The paragraph in green beneath it describes the absence of ALK fusion protein, which rules out that abnormality. And the red paragraphs, bottom right, describe the presence of the L858R mutation and some interpretation of what that means. So it's all brought together, and I think that's also very important. What the clinician needs is all of the information in one place in a timely fashion. It's not an easy task to achieve, but it is achievable. And we have very few pathologists, if any, in the room now. I think Eric might have disappeared. But whenever I speak to groups of pathologists, which is frequent, of course, I always make the point to them that all of this genomics is just another aspect of pathology. It's just a different way of looking at the tumour. In practice, in essence, it's no difficult from looking down the microscope at an H&E stained section. It's not exotic, and it shouldn't frighten them. And I'll leave you with the thought that I always leave them in a moment. What about the future? Well, we talk a lot about gene sequencing, next generation gene sequencing, in which we can get a printout of endless genetic abnormalities, and that's fine. I think it's fantastic. It does have problems. It's not quite as straightforward as it's often made out to be. It's not quite as cheap as it's often made out to be, but it's fantastic information. But it's not all usable, of course. We have to know what we can do with information. I think it's always worth reminding ourselves that information is not the same as knowledge. So it's okay having it at our fingertips, but it has to mean something. Circulating tumour cells and DNA, and indeed educated platelets that we heard about today, I think this is a major step forward, of course. And I think within a very short period of time, looking for EGFRG mutations to detect T790M mutation in blood samples will be routine. And in that particular context, will probably replace the need for tissue. However, one thing which does worry me about all this optimism around the use of circulating DNA is that we mustn't give out the message that a biopsy is no longer necessary. I think that would be catastrophic. Because no matter how available genomic profiling is, and no matter how prevalent analysis of circulating blood is, you can't, for example, look for PD-L1 expression by either of those techniques because you need cells in a section. So these are tremendous in their place, but they're not an answer to everything by any means. And that final thought, it's all just pathology at the end of the day. Thank you very much indeed.